So hello, I am Sabina Nuti. I am a professor in Sant'Anna School in Pisa. Sant'Anna School, it's a public university. It's quite a particular university because we are in charge for all the Italian country to form and to educate the best Italian students in applied science. Since 10 years ago, more or less, the Tuscany region asked us to develop and to implement in our region the first performance evaluation system for healthcare, the first one in Italy. And so we did a big work, very long work, to find out which was the best type of indicators that we could use to measure performance in our healthcare system. Since 2003, our counselor, healthcare counselor at the regional level, that it's in charge for all the public system, that in Tuscany it's around 95% of our hospital beds, just to understand like how important is for us the public sector. And he had in his hands only the balance and so the economic and financial indicators, but he didn't know really what the different local health authorities working in primary care and in hospital care, what were the results that they could achieve with the money that they had in their hands. And so we started to develop this system. And now, since 2006, is the system that the region adopted at no more in an experimental way, but as the normal system that is used to evaluate results every year and also to plan what to do for the future. And it has now been adopted also by other 8 Italian regions. So now we spread out this type of system. Why it's important to speak about this performance evaluation system? Because inside this performance evaluation system we find a very important position for the APA indicators. And this means something very important, that APA goals, the efforts that the local health authorities are asked to do to spread out these type of activities has been considered as a priority, a strategic priority, and so important that has to be monitored at regional level. And it's linked to the rewarding system of our CEO, CEO of the local health authorities and all the management of our organizations. So if you think I could just describe you a little bit this performance evaluation system. Think that in Tuscany we have 12 local health authorities with a lot of people working inside the system. At the regional level, more or less, we have 51,000 persons working in the public system, and 12 local health authorities and 4 teaching hospitals. And it was very important to have a system that could that could be used as a tool to share priorities and strategy at the regional level. So working with physicians, nurses, and management at the regional level, we find out that to measure performance, it was important to think about different dimensions. And these dimensions are the level of health of population as the first important goal to achieve. Everybody is working, trying to have a better level of health for our population. But we know that this type of target can be achieved only in long time. And so it's quite difficult to think that these also if they are very, very important, are the indicators that we should look every month or every year, just to measure how good we are working. And so we thought that next to the outcomes, we should have some other different dimensions. And so the outcomes, the outputs measured in quality of care and appropriateness of what we're doing for the health of our citizens. And this is a second dimension. The capacity to follow the regional strategies, because it's very important that if the strategic plan of the region points out that, for example, APA programs are important to have a better health for our citizens, everybody in the system has clear that this is a priority. So we thought to select in this dimension some important targets that have to be shared at a regional level. And then we have a third dimension that regards the point of view of citizens, and so patient and citizen satisfaction, the point of view of the person that are working in the organization, so the organizational climate inside all the different settings of care, because we found out that having people happy to work in the organization can help a lot in improving health outcomes for patients. And then the sixth dimension is efficiency and financial sustainability, that as you can understand, it's very important in Italy like in all the rest of the world, because costs in healthcare are very difficult to be managed and to be able not to increase too much cost, so that they can be sustainable for our community. With the sixth dimension, we find out about 200 indicators. And then we thought that we should have a way of evaluating these different indicators, not only measure them. And so we decided to divide our, to evaluate in 5 classes, coloring also our results with different colors. So green, dark green, if the result achieved is a very, very good result. And then light green is not really very good. And then yellow and orange, we are already in a quite situation that needs attention. And of course, red is a terrific situation where we need to do immediately something to change the situation. So 5 colors, 200 indicators, classified in 6 dimensions, and then we thought, how can we put everything together? Usually in the management studies, it's usually used the spider net to represent different dimensions and different goals to be achieved. But we thought that the metaphor for this type of way of representing the performance wasn't really very challenging, because if you get something wrong, you just go in the mouth of the spider. It's not really very motivating. So we thought to change this idea, and we thought about a target. So if you get the target, you just go in the center of the target, and the more you are far away from the goal, the more you are not near the center of the target. I could show you these are the 5. This is, for example, a target. This is for our local health authority in Massa. You can see the different points that can show for each indicator what is the situation, what is the performance for example, in this case, the local health authority of Massa, or this is Lucca, or this is Pistoia, Prato, and so on. So each local health authority every year has a target that shows where is the performance, where is the position. Of course, the position that each local health authority is measured considering the benchmarking with the other local health authorities. The starting points are the same, so we would like all the local health authorities to achieve the maximum of the goal, and also to reduce variability among different local health authorities. So, as I told you before, APA project became a priority after the first experience carried out from Empoli. The region thought that it was very important to spread out this experience. So it was shared with the CEO an indicator that measures the number of courses that are organized for high and low disability. It was set a goal to be achieved, and we started to measure since 2009 the capacity of all the local health authorities to achieve these targets. And so I could show you these indicators. Let me go, this is Empoli. And this is the APA. As you see, is the first local health authorities. They did very well. And all the other local health authorities say, well, they did well because they started before and they had a very good person helping them to it. So this is in the indicators. The indicator is B22, is one of the points that is in the target. You see the very good performance of Empoli, that, as I told you, was the local health authority that started first. But you can see that all the others already have organized some work. This is data of 2011. We can see that we have done some work in improving. I have also specific data on this. I could say that in the last year, we had an improvement around 30% of number of persons that are participating at the regional level. Of course, this is not the same in all the different local health authorities. Unfortunately, we have Arezzo and Pistoia that, especially for courses that with high disability, are still didn't start. We can see that regarding this indicator, we had a very good capacity of improvement. It's around 30%. And also it's important to understand that this is not the only indicator that is inside the performance evaluation system regarding physical activity, because this is one of the indicators. Then we measure the capacity of primary care to I would say push patients to do physical activity, and we measure this asking to patients if in the last year their family doctor asked them to do physical activity, and if they were inside a program that so this is very important, because of course if you ask a family doctor, he always says that he does it, but we have to verify with the patient if it's true. And we also have some indicators inside the outcomes that measure how many persons are overweight and the capacity to put them under control. So this is something very important, because we have to think that the APA indicators are inside more large strategies that makes different points of the system all in charge to achieve the same goal, that is healthy people. That moves a lot. So for example, this year we have a new indicator that will measure, and asking to patients that have been in hospital, if somebody during the period that they were in hospital spoke about them, how important is physical activity, and introduce them, if they have chronic illness, to the APA projects. And so this is a way to consider that this issue is a system issue. It's not only of the person that organized the courses, but it's something that's integrated with all. Of course, when we have indicators that present data in benchmarking, one of the first problems that we have that a lot of person, especially in the first period when they are in front of the data and thinking about why they have different performance, the first attitude is to say, well, I am different. My patients are different and we can't measure. I think that this was a problem we had, especially the first years. Now variability is so high that can't never been explained by health needs of the patient. There's much, much more. And now everybody has, because we tried and we did risk adjustment with a lot of factors, showing them that in the majority of cases, the higher percentage of difference depends not on health needs, but depends on organizational choices. And especially, not even depends on the capacity, professional capacity of our physicians or nurses. But most of the time is the type of decisions that the organization does, is how to organize the path, or how to put person together, how to organize the team, or how to organize the communication flows of information. This makes the difference. And so I think that now I think we started in 2006, and this means a lot. And now this is something we got over with it. Now people, when they see the data, they start working why. And this is quite interesting because also they are much more comfortable that the data that show such a differences are not data to punish, but are data that help all the system to think about what is the reason that makes, for example, Empoli so good and Pistoia so bad. So in a way, I think that the secret of the system, it's based on a lot of elements that put together makes the difference. For example, the performance evaluation system, has a public disclosure, works really a lot on reputation. It's also linked to the incentive system and to the wording system for the CEO. The CEO have about 20% of their salary linked to the incentive system. But the region gives the incentives only with the CEO, at the CEO. Then the levels and the line under the CEO depend on the budget system of each local health authorities. So each local health authority uses this data to incentive the results inside the local health authority. But our public contract with the workers doesn't allow a high percentage of incentives. This is only possible for the CEO. So really, when you go under and you go and see our leaders inside the organization, what really counts is not money, but it's reputation. They don't like to be at the end of the ranking. And so this started a good, I would say, a good competition. That's a competition on quality, because it's important to remember that Tuscany is all public. It doesn't work on a market, on a private market, but we want to push a lot competition on quality. And so this is, I think it's a good competition because it regards appropriateness and quality of care. So I would say public disclosure, connection with the rewarding system, connection with the training courses for the management. That means that we as a university, a public university, we are in charge as a third subject outside the system to measure the indicators and to publish them. And so in this way we can guarantee, you know, the rigors about the measure that we use. But we are also in charge to train the management of the region and of the local health authorities. The law in Italy asks the CEO and each head of the department that when they get in charge of this type of position, they have to do a training course, quite long. It's about 150 hours in a year, so it's quite a long course. And we are in charge to offer this type of course. So we are able, in a way, to close the circle. We evaluate them, we decide with them, sharing with them which indicators use. With the region, we fix the target for the next year. And we are able to work with them, showing them the best practice in the region in the training courses. So it's a way to enhance, to bring out the best practice that are in the region. In a public system, usually a lot of problems come out. The press doesn't help us because it's always speaking about what big queues there are in the, for example, in the emergency department. But there are really a lot of nice stories inside our system. This way, having some quantitative data and some evidence on management, because we have usually the evidence in the clinical side, but here we have some evidence on the managerial side. Mm-hmm. And having a way to give value of the good, to the good experience helps a lot in motivating person to do their job every day in front of their patients. So this, I think, is quite important. Do we have any evidence that this system works considering other experiences in the Italian regions? Well, I'm happy to say yes. So I will give you some of the papers that we published in the last 2 years. We had, for example, because the problem is that we can do this type of benchmarking if we have the same type of indicators used or the same. And with the National Agency for Healthcare, we did the work together to see what was happening in Italy, for example, regarding a very important indicator that it's about being able to do the intervention for hip fracture in 48 hours. We had a very high variability in Italy. We had the medium in Italy was 30%, with a lot of regions on back of this indicator, and just few of them in very high positions. This was the situation in 2006, and from 2006, Tuscany region started to put this very important indicator in our target and start to work with the professional to find out what was the path that we should have in our hospital to improve this, to have this intervention timely. And it's very nice to see that after looking at the same data after 2 years, all the region were at the same percentage. Some of them even went backwards, and Tuscany was the only region that really did a very big improvement, passing from 30% that time at 45, now we are over 60. So what is sure that this system helps the region to improve much more and much quicker. We have Lazio region, for example, in this indicator that linked the goal with the changing the price for the DRG, you know, for this type of intervention, and paying more if it was done in a quicker time. The improvement was 1%, really very little, and that demonstrates that physicians don't really care about money, but they care much more about quality and about reputation. So this is a way of improving.
At least in Italy, that's true. Yes.
At least in Italy.
So, Sabina, let's talk a little bit more about this point that you have just made that says that this system is really working. I think that's very important because so often we think that just putting a financial incentive on a DRG is going to make the successful story. And in fact, we know from the United States this often doesn't happen. And so I think there are two factors that I've heard you talk about that have helped the system be effective. And one was that in the beginning, there was a lot of discussion with your managers about what factors they thought was important. Could you say something about that?
Yes, I think that something that is very important to make the system effective, that you don't have to be in a hurry. You have to have time, because you need that each professional's has to be involved in the process. You just can't say these are the indicators that were decided from the region, because a good professional will never accept hierarchy. He is a professional and he wants to be involved in the decision-making process. And so usually at the beginning, really about 2-3 years just before selecting which indicators and which topics were the most important to be measured first, and a lot of work looking at all the evidence that was already available in the rest of the world. And so a big workup from this point of view. But still now, every year we have new indicators getting in and some going out, because perhaps all the region achieved the goal and they're not important anymore. In this process, it's very important that we always have the door open. Each professional can propose a new indicator, can give suggestion, or perhaps we can give a suggestion. We have some reunion with getting together all the professionals of the region. From this point of view, I think that the dimension of our region helps us a lot. Because, for example, if I put together all the responsible of the emergency department, I can put them in a room and discuss with them. We will be about 60-70% considering nurses and things, and we're still a number that can be managed. And the first year, the indicators is measured but not evaluated. And this makes time that everybody thinks about it and can say if they don't agree. The next year, it will be a performance evaluation indicator. And so in this way, even if sometimes you would like to be faster, but you can't push too much, because otherwise you will find some resistance about the professional that won't accept the indicator and they will work against. I don't think that it's better to wait, that everybody's ready. That, of course, what happens also is that sometimes, even if you have waited the right time, when at the end it becomes a performance indicator and is evaluated, you can still have professionals that don't believe because they say that in their situation, the patients they had were still different, that can't be measured. So we found this way that the professional that thinks that his patient couldn't do that type of path because they were in a way different, it's their responsibility to fix like a report with all the data of each patient and send it to us and to the region, and ask that with signing the request, that these patients have to be out of the measurement process. And this makes feel comfortable the professional, that he will never have to be to find a situation against his professional responsibility. And the reality that the cases that we have, we can count them on a hand. Because really, when it's the moment, it comes out because he has to present this responsibility to other colleagues, and the peer review is quite important. We found out that we never had just few cases, only for some diabetic cases, but for the rest, all the indicators, we found a way.
But the key here is that if you have a physician whose patients are seriously more ill, have more complexity, more comorbidity, that person has a way to ask to be acknowledged. Yes. For that work. Yeah. So he doesn't worry that he'll be penalized for.
But he has to get the responsibility to say why they are different patients, and to explain to the colleagues why he wants a different treatment.
Right.
And this, at the end, it's a good way to do a big selection, because then at the end, most of them realize that they don't really have these cases. If the indicator is well built.
Yeah. So another factor that I've heard you talk about is how you set the targets for each health authority to reflect where they started. So perhaps you could say a little more about that.
Yes, we realized that, of course, measuring and not measuring a factor change the performance. If you measure, you have a better performance just because everybody pays more attention. If we not only measure, but we link the measurement to the rewarding system, we found out that we have 2.7 points more of improvement, considering it without incentive. And then in 2008, we started to fix the target, not the same for each local health authorities, but we started to consider the starting point. So not the same target for all the region, but we said the real goal for the region is reduce variability. If we give a target too high to the to the worst local health authorities, he could be not motivated because he will never achieve it. So we started to build like a line, considering that we wanted the region to achieve the point of the median above the medium. It's a little bit complicated, but we wanted from the medium of the region to achieve the new position. It was the medium of all the local health authorities are above the medium. So this was the target for the region, because we said we can arrive there. That's possible because we know somebody is already there. And then from this, we fixed the targets for each local health authorities, asking more to the one that had the worst, but not asking in the first year to achieve the target of the region. And this helped us to have a better improvement because each local health authorities thought that it was considered the difficulties. So at the end, this helped to reduce variability and to have a better global improvement.
So I want to thank you for taking your time today to talk about this system with us. This is very important, what you're learning and what you're sharing with us. We've been interested in what you were doing since you first began, and as time goes on, to be able to see how you can structure your performance measurement system to get the most response from the professionals who are working to make a better care for their patients. And this is so important because for all of us in the years to come, we have less money and more aging people and more chronic disease is possible. And so we want to understand how to make things better. And I'd like to thank you particularly for talking about how the APA program became included in the measurement system and how this indicator is particularly important for prevention, for making people healthier. And your indicators go across the whole spread. I think you said there were 22 indicators in the beginning.
No, yes, at the beginning we started with about 50 global indicators. Now there are much more, but then we have a synthesis in the in the target. Mm-hmm. And APA always have been a point because it has also been considered very important. Mm-hmm. And it's very important to give this message that is important, like the screening, oncological screening, or like quality of care, or it's there, and this helps a lot people to understand that working on that program is considered a strategic priority.
So thank you very much.